Imagine waking up. You walk into your bathroom and you look in the mirror.
Yeah.
You try to smile at your reflection, but like only half of your face responds.
Right.
The other half is just completely still, maybe sagging a little bit.
Yeah.
You try to blink, and one eye just stays open.
Yeah, it's a terrifying scenario.
I mean, your brain is setting the command, it's desperately firing the signal, but the hardware is basically crashed.
Yeah.
And for a lot of people, the immediate panic is, they think they're having a stroke.
Oh, absolutely. That's the first thing everyone thinks. But often, it's actually something entirely different. It's a biological short circuit in a very specific, highly vulnerable piece of bodily machinery.
Right.
And it reveals a truth we usually just ignore, which is that the human face is this absolute marvel of engineering, but it operates on a razor's edge.
Yeah.
Facial palsy, which is the paralysis we're talking here, is just devastating. I mean, it strips away your ability to communicate emotion non-verbally.
You literally lose your smile.
You lose your smile. You lose the ability to eat without spilling, to speak clearly, to even protect your own vision. It's a really profound functional and psychosocial crisis.
So today, we are taking a deep dive into the biological machinery behind every expression you make. We are unpacking the facial nerve, which is medically known as cranial nerve 7.
Yep, cranial nerve 7.
And we're using some fascinating source material from Scott Brown's Otolaryngology, specifically looking at the non-neoplastic disorders.
Right, so the catastrophic glitches that aren't caused by tumor.
Exactly. Our mission today is to understand how this incredibly delicate hardware is routed through your skull, what happens when it breaks down, and honestly, the truly bizarre ways your body tries to wire itself back together in the aftermath.
Yeah, and to really grasp how things go wrong, we have to look at what this nerve is actually doing. Because calling it the facial nerve is, it's kind of a massive understatement.
It's not just a smile nerve.
No, not at all. It doesn't just flex your cheek muscles. It's this incredibly complex bundle of fibers carrying like vastly different types of data all at the exact same time.
So we shouldn't think of it like a simple copper wire running to a light bulb.
Mhm.
It's more like a massive transatlantic underwater communication cable.
That is exactly it.
You've got your high-speed internet, your secure military channels, your telephone lines, all wrapped up in a single heavy sheath.
That is the perfect way to visualize it. Because inside that single sheath, you have motor axons handling voluntary movement, so your smile, your blink.
Right.
But packed right alongside them are special sensory fibers. And these carry taste from the front 2/3 of your tongue.
Wait, taste.
Yeah, taste. It travels up a specific branch called the chorda tympani, and then you have general sensory fibers registering feeling from your external ear canal.
So movement, taste, ear sensation.
And we're not done. Finally, you have parasympathetic fibers. These are the automatic background signals that instruct your lacrimal glands to produce tears and your submandibular glands to produce saliva.
That is so much data crammed into one pipe. Movement, taste, touch, tears, and saliva.
All in one.
And that pipe has to navigate an absolute obstacle course through the skull, right? Because it starts deep at the base of the brain in this crowded junction box called the cerebellopontine.
Right.
And from there, it dives directly into the dense, solid bone of your skull, the temporal bone. And then finally, it exits out into your cheek, passing right through your parotid salivary gland, where it fans out to control the face.
Yeah, and we can actually map that final fan out on our own bodies, which is pretty cool. If you place the heel of your hand on your cheek, like right next to your ear, and spread your 5 fingers wide across your face, that maps exactly to the 5 main extratemporal branches.
That's a neat trick.
Right, so your thumb pointing up toward your forehead is the temporal branch. The index finger pointing to your eye is the zygomatic.
Got it.
The middle finger on your cheek is the buccal. The ring finger pointing to your jawline is the marginal mandibular. And your pinky pointing down is the circle branch.
It's a really brilliant distribution network. But, looking at the internal routing, nature seems to have made this massive design flaw.
Oh, totally.
Because before the nerve even gets to the face, while it's still trapped inside that solid bone of the skull, it passes through this specific bottleneck called the labyrinthine segment. And I have to ask, why would a nerve carrying such critical, multifunctional data be routed through this inflexible, microscopic bony tunnel?
Well, it's a great question, and the labyrinthine segment is exactly where the catastrophe usually begins. Because this bony canal is brutally narrow. The segment itself is only 3 to 5 millimeters long.
Well, that's tiny.
In biological terms, it is a tiny choke point, but the real structural flaw isn't just the size, it's the blood supply. That specific 3 to 5 millimeter stretch is primarily fed by a single artery.
Only one.
Just one. There's almost no collateral blood flow with no backup system at all.
So if a virus or an infection causes the nerve to become inflamed, there's zero room for expansion. Because the bone around it isn't going to budge.
Exactly. The nerve swells, and it immediately crushes itself against the walls of the canal.
It essentially strangles its own flimsy blood supply.
That's exactly what happens.
Yeah.
That compression leads to ischemia, which is a severe lack of blood flow and oxygen. The nerve cells suffocate, and that ischemia is what causes the sudden overnight failure of the signal. The hardware just drops offline.
But a drop signal doesn't really tell us what's actually happening inside that bundle of wires.
Right.
The nerve suffocates, sure, but how bad is the internal damage? Surgeons need to know if the structure is just bruised or entirely destroyed.
Right, and this is where Seddon's classification of nerve injury becomes critical, because it breaks down the severity into 3 biological categories, starting with the mildest one, which is neuropraxia.
Okay, let's use our underwater cable analogy here.
Yeah.
So neuropraxia is like a temporary power outage on the grid, right? Like something puts pressure on the underwater cable, maybe a sunken ship is resting on it.
Right.
The data stops flowing instantly. But the internal wires and the heavy rubber insulation around them, they're physically perfectly fine.
Yep.
Once you remove the pressure, the system boots back up and you get a full 100% recovery in a matter of days or weeks.
That's a perfect analogy. The structure remains entirely intact, but the next level up, however, is a much more destructive tier called axonotmesis.
Okay, so in axonotmesis, the pressure is so intense that the internal copper wires of our underwater cable actually melt and shatter.
Right.
But the thick outer rubber insulation of the sheath somehow survives that.
It does, and biologically, this initiates a massive, incredibly exhausting rebuilding phase known as Wallerian degeneration.
Wallerian degeneration.
Yeah, the nerve cannot just patch the broken internal wire. It doesn't work like that. The entire segment of the axon that sits downstream from the injury has to deliberately die off.
But it kills itself off.
It does. The body sends in these cellular cleanup crews, macrophages, to clear out the microscopic debris of the shattered axon. And what is left behind is a hollow, empty tube formed by the surviving outer sheath.
Wow.
So then the nerve has to slowly grow a brand new fiber all the way down that empty tube to reach the muscle again.
So it has to completely repave the highway.
Exactly. And then we have the absolute worst case scenario, which is neuromesis.
Let me guess. The submarine propeller slices completely through the cable.
You got it. Neuromesis is total transection. The internal wires and the outer insulation are severed in half. The ends just recoil away from each other.
So without a surgeon going in, actually opening the skull or the face, and physically, microscopically stitching those two ends back together, no signal will ever pass through again.
Never. Now, while Seddon's classification defines microscopic damage, a doctor in the emergency room needs a standardized way to evaluate what they can visually see on the patient's face right then and there.
Right, they can't see the microscopic wires.
Exactly. So they use the House-Grafton scale, which grades the visible dysfunction. Grade 1 is perfectly normal, healthy movement, and it scales all the way to grade the 6th, which is total flaccid paralysis.
Like no movement, not even a twitch.
Right.
But the distinction between the middle grades seems incredibly specific. It's like the boundary between a grade 3rd, which is moderate dysfunction, and a grade 3rd, which is moderately severe, it all comes down to one single capability. It hinges on whether the patient can close their eyelid completely.
Yep.
Why is eye closure the defining metric there?
Because eye closure represents a threshold of medical emergency. You see, the House-Grafton scale isn't a cosmetic index. It's tracking functional danger.
Okay.
If a patient is at grade the 3rd, their smile might be pretty crooked and their face is noticeably weak. But if they squeeze their facial muscles with maximal effort, the eyelid shuts.
So the windshield wiper still functions. The eye stays moist.
Exactly. The moment that patient slips to a grade the 4th, they lose the ability to force the eyelid completely shut. The eye remains perpetually cracked.
Oh, that sounds awful.
It is, because without that physical barrier and the distribution of tears, corneal exposure sets in rapidly. The surface of the eye dries out, microscopic abrasions form, and it can actually progress to severe corneal ulceration.
So they can go blind.
Yes, the patient is at high risk of permanent blindness in that eye. That is exactly why the eyelid defines the grades.
Okay, so if a patient presents with a grade the 6th total paralysis, the immediate instinct would be to run an internal diagnostic, right? Like, let's hook him up to a machine and see if the nerve is severed or just sleeping.
Naturally, yeah.
Doctors use electrophysiological testing, like an ENaU, to send electrical pulses into the nerve and measure the degeneration. But there is a wild biological quirk here that the sources point out.
Oh, yeah.
If someone wakes up completely paralyzed today, the protocol dictates you actually have to wait 4 to 21 days to run that ENaU test. If the face is totally dead right now, why in the world are we waiting weeks to scan it?
It's so counterintuitive, but it all comes back to the mechanics of Wallerian degeneration. Remember how the nerve clears out the debris?
Right, the macrophage cleanup crew.
Well, when that nerve is crushed inside the bony tunnel, the long stretch of the nerve that extends out of the skull and down into the face doesn't instantly realize it has been cut off from headquarters.
Oh, it's like a severed tree branch. The leaves don't turn brown the exact second you chop it off the trunk. They stay green for days.
That's brilliant. Yes, the distal axon, part of the wire running through the cheek, actually maintains its electrical excitability for up to 72 hours, sometimes even longer.
Wow.
So if you attach electrodes and run an ENaU test on day 2, the electrical pulse will jump through that disconnected piece of wire perfectly, and the machine will spit out a false positive.
It'll tell the surgeon the nerve is perfectly healthy.
Exactly, when in reality it is completely severed upstream. So the surgeon has to wait for biological decay to physically travel down the length of the nerve.
That is wild.
Only after about 4 days does the debris clear out enough for the machine to accurately confirm that the wire is dead. They're looking for a degeneration threshold of over 90%.
So if the machine confirms the nerve is severely degenerated, the immediate question becomes, who killed it?
Yeah.
What actually infiltrated that tiny bony tunnel to cause the swelling in the first place?
Right, and the vast majority of acute unilateral facial paralysis cases are diagnosed as Bell's palsy.
Bell's palsy.
Yeah, and for decades it was considered entirely idiopathic, just a total medical mystery. But we now understand it's highly associated with the reactivation of herpes simplex virus type 1 or HSV1.
Wait, if Bell's palsy is caused by a virus waking up and creating inflammation, couldn't other, more aggressive viruses do the exact same thing? Is there a worse version of this?
Unfortunately, there is, and it's called Ramsay-Hunt syndrome. This is caused by the varicella zoster virus, the exact same pathogen responsible for chickenpox and shingles.
Oh, wow.
Yeah, after a childhood chickenpox infection, the virus retreats and hibernates inside a cluster of nerve cell bodies called the geniculate ganglion, which sits right on the facial nerve, and then decades later it can reactivate.
And when Ramsay-Hunt strikes, the sources say it is brutal. While 70% of Bell's palsy patients make a full spontaneous recovery, only about 10% of Ramsay-Hunt patients regain full normal function.
Just 10%. It violently attacks the nerve, causing these incredibly painful, blistering eruptions in the ear canal or even inside the mouth.
And because that inflammation in the tight bony canal is so severe, it spills over, right? It compresses the neighboring cranial nerve 8, which is the vestibulocochlear nerve.
Right.
So alongside facial paralysis, patients hit with sudden hearing loss and intense debilitating vertigo.
It's a really miserable experience for the patient.
And beyond the viruses, the biological hardware can also just fail during human development. There are conditions like Mobius syndrome, where newborns are delivered with congenital bilateral facial paralysis, like their faces are perfectly still from birth.
Yeah, Mobius syndrome is a fascinating and tragic failure of embryology. The cranial nerves simply do not form properly in the womb. The hardware is just missing entirely.
Wow.
And similarly, there's Melkerson-Rosenthal syndrome, which is this really rare condition that causes alternating facial palsy.
Alternating.
Yeah, one side goes down, recovers, and then the other side goes down. And it's often accompanied by severely swollen lips and a deeply fissured, kind of cracked-looking tongue.
That is so strange. But let's look at what happens when the hardware tries to fix itself. We talked about Wallerian degeneration, the nerve clearing out the dead debris and slowly growing a new wire down the empty tube.
Right.
The speed of that regrowth is agonizing. The nerve fibers literally crawl forward at a rate of roughly 1 millimeter per day.
1 millimeter a day. It means that if the crush injury happened deep inside the skull, it could take a year for those regenerating fibers to finally reach the muscles of the chin or the forehead.
And a lot can go wrong in a year. Imagine trying to thread thousands of microscopic wires through a dark tunnel. Sometimes they take a wrong turn, the wires get crossed.
Me too.
This is called aberrant regeneration. It's like plugging your computer keyboard into the mouse port. The brain sends the correct signal to type a letter, but instead, the cursor wildly clicks across the screen.
I love that analogy. This physiological rewiring leads to a mass movement disorder known as synkinesis.
Synkinesis.
Right. So as the motor fibers regrow, a fiber that originally powered the mouth might accidentally branch off and connect to the muscles surrounding the eye.
Oh no.
Yeah, so when the patient naturally attempts to smile, the brain fires the smile command, but that signal travels down the split wire. Their mouth lifts, but their eye involuntarily clamps shut at the exact same time.
So they literally can't stop it. It is a permanent physical hardwiring error.
Exactly, they cannot consciously stop it. The primary management for synkinesis relies on targeted botulinum toxin, or Botox.
Oh, they use Botox for that.
Yeah. By injecting Botox into the specific incorrectly wired muscles, it blocks the release of acetylcholine at the neuromuscular junction. It essentially mutes the rogue signal.
So paralyzing that specific muscle just enough so the patient can smile without their eye aggressively twitching or closing.
Exactly. But the ultimate biological glitch happens with those parasympathetic fibers we mentioned earlier.
The ones handling the background tasks.
Right. If those microscopic wires get scrambled during that 1 millimeter a day regrowth, you get something called crocodile tears syndrome.
Wait, real crocodile tears.
Real crocodile tears. The salivary fibers, the ones meant to make you drool when you see food, they lose their way and plug themselves into the lacrimal gland, the tear ducts.
So gustatory lacrimation, the physical boundary separating digestion and emotion, basically vanishes.
Right. Whenever the patient sits down to eat a meal, the saliva command fires, hits the tear ducts instead, and they literally begin to actively cry.
That is just mind-blowing. So when a patient is sitting in the clinic, unable to close their eye, maybe crying when they eat, the surgeons aren't just sitting back and watching the clock. They're actively hunting for the exact location of the crush injury inside the skull.
Absolutely.
But how do you find a microscopic pinch point without just cutting the head open?
You have to conduct topodiagnostic testing. Because the facial nerve branches off sequentially, kind of like exits on a highway, doctors can test the specific functions to map the damage.
Oh, I see.
Yeah, so they use a Schirmer's test, placing small strips of filter paper in the eyes to measure tear production. If the paralyzed side is bone dry, the surgeon knows the crush injury happened very high up before the tear duct exit.
And if the eye waters normally?
Then they do an electrosometry test, which sends tiny currents to the tongue to check for taste. If there's a total loss of taste, they know the damage is further down the line.
That is brilliant biological detective work. But I want to push back on a massive contradiction here regarding the timeline of recovery.
Okay, lay it on me.
We established that the nerve regrows at 1 millimeter a day. The body is clearly designed for a slow, agonizingly long rebuilding process.
Right.
Yet the surgical protocols strictly enforce a rule of 12. They state there is a hard 12 to 18-month window for dynamic nerve repair. Why is there a hard deadline if the nerve itself is willing to keep growing?
Well, because the surgeon isn't worried about the nerve at that point. They are worried about the target. The rule exists because in surgery, time is muscle.
Time is muscle.
Yes, when a facial muscle is completely disconnected from its electrical supply, the specialized junction where the nerve plugs into the muscle fiber, the motor end plate, it begins to biologically degrade.
Oh, so the outlet breaks.
Exactly. After 12 to 18 months of complete silence, that target muscle undergoes irreversible atrophy. It physically turns to scar tissue.
So even if the nerve bravely crawls its way down the face and arrives at, say, month 19, or a surgeon comes in and expertly slices a new nerve in,
Yeah.
it just doesn't matter. The outlet is dead.
Exactly. The muscle will never accept an electrical signal again. But if a surgeon intercepts the patient within that critical 12-month window, they can perform dynamic reanimation. They might perform a nerve transfer, taking the hypoglossal nerve, which normally moves the tongue, and rerouting it to the facial nerve to pump electrical life back into the facial muscles.
But what happens if they miss the window? Like if the muscle has already turned to scar tissue, how do you fix a paralyzed face?
At that point, surgeons have to deploy incredibly complex free tissue transfers, like the gracilis free muscle transfer.
Gracilis, wait, isn't that in the leg?
Yes. They physically harvest a segment of the gracilis muscle from the patient's inner thigh, along with its dedicated artery, vein, and motor nerve.
That is wild.
And they transplant that thigh muscle into the cheek, microscopically plumbing the blood vessels into the vessels of the face and hooking the thigh nerve up to a working nerve branch, sometimes even tunneling a nerve from the healthy side of the face.
So it gives the patient a brand new working muscle to power a smile.
Exactly.
But what if massive surgery just isn't an option?
Then they rely on static procedures. They basically abandon movement entirely and focus purely on symmetry and gravity.
Okay, so going right back to the House-Bracknett emergency, the eye.
Right. The most vital static procedure is for the eye. Surgeons will implant small, precisely measured gold or platinum weights directly into the upper eyelid.
Gold weights.
Yeah, so the patient uses their healthy muscle to open the eye, but when they relax, the gravity of the gold weight physically pulls the eyelid shut, protecting the cornea.
It is a purely mechanical solution to a biological failure.
It really is.
So we have traced cranial nerve 7th from its origin deep inside the brainstem, squeezing through a tiny 3mm tunnel where a single hibernating virus could just choke off its blood supply.
Yep.
We've explored the brutal reality of Wallerian degeneration, the agonizing 1mm crawl of recovery, and the relentless 12-month clock ticking against irreversible muscle death.
The facial nerve really illustrates perfectly how much raw, fragile complexity is required just to raise an eyebrow or shed a tear.
It really does. And it leaves me thinking about those bizarre miswirings, the crocodile tears and the synchronicity.
Maybe crossed wires.
When the facial nerve suffers trauma, its desperate attempt to heal can literally rewire our sense of taste directly to our tear ducts. It is a profound microscopic glitch.
Definitely.
And it makes you wonder, if a single damaged nerve can physically scramble how we eat and cry, what other crossed wires are happening throughout our nervous system right now? What microscopic, unnoticed biological glitches are silently shaping how you perceive the world, altering your moods or changing your reactions without you ever realizing there's been a short in the system? Something to think about the next time you smile.